Good afternoon, everyone. My name is Victor Salazar Calderon. I am a neurologist in private practice here in Phoenix, South Phoenix. And I was asked by Dr. Paul Underwood, just to participate in this health fair. And I'm going to talk a little bit about dementia, stroke, and seizures. Probably also, Paul, you allow me to present something about syncope, because you told me in one of your emails about, just talking about syncope. Dementia, you have heard a lot about dementia, which is a neurodegenerative disease of the brain. And there are many medical conditions that can cause dementia. Being the number one cause of dementia, Alzheimer's disease. As many as 75 to 85% of patients with dementia, they have Alzheimer's disease. And the other 25% of people who do not have Alzheimer's disease, they can have combination of vascular dementia with Alzheimer's disease. They can have Lewy body dementia. They can have frontotemporal dementia, Pick's dementia. They can have age dementia, alcoholic dementia, Creutzfeldt-Jakob dementia, Huntington's dementia. There are different types of dementia, but not everyone has Alzheimer's disease. I should say, for example, that maybe at the age of 65, we may have about 7% chance of having dementia. In many times, people have not been diagnosed with dementia. At the age of 75, it's around 34% of people, may have dementia. Again, they have not been diagnosed. At the age of 85, it's around 47%. And at the age of 90, it's about 90%. Patients who have, for example, medical conditions such as Down syndrome, they can experience symptoms of dementia as early as age 40. Now, do we have a cure for dementia? And the answer is no, unfortunately, we do not. And right now, we do have only 5 medications that have been approved for the treatment of dementia. 3 of them belong to a same class. They are called anticholinesterase inhibitors. Another one, which is memantine, brand name Namenda, which is an NMDA receptor blocker. And the other one, the latest one that was approved in June last year, which is a monoclonal antibody aducanumab. It was a rapidly approved, and it is a medication that will be the first medication that we have that is actually modifying the natural history of the disease, because the first two that I mentioned, the anticholinesterase or cholinesterase inhibitor, which are 3 of them, plus memantine, the only thing that they do is just to slow down the progression of the symptoms. We are actually not slowing the disease. We are not stopping the disease, and much less we are not curing anything. We need, as soon as we have a patient or a relative of ours who is encountered, who we notice that the patient is having some cognitive impairment, we should refer the patient to a neurologist or to the specialist to make sure that the patient does not have the beginning of dementia. Why? Because as I said at the beginning, not everybody may have Alzheimer's disease. They may have a different kind of dementia that may be treatable. For example, there are some vitamin deficiencies, that can cause dementia. Among them, especially vitamin B12. We also, that folate can cause memory issues. Vitamin D deficiency can cause memory issues. Medical conditions such as hypothyroidism, can also cause, this memory impairment. Therefore, it's a good idea, just to refer those patients to the specialist and to rule out or rule in dementia. Sometimes, just being forgetful can be completely normal, as we are aging, because aging is a risk factor for getting dementia. We don't see younger people with dementia, really. I mean, there are exceptions to the rule, of course, but, usually, Alzheimer's disease, which is the commonest type of dementia, usually we begin to diagnose it after the age of 65. Remember that women have more tendency to have Alzheimer's disease than men, and the only reason really it is because they outlive us. They live longer than we do, therefore they have a higher risk of developing the disease. Now, at the beginning of dementia, people can begin just having mild cognitive impairment, and we have 2 forms of mild cognitive impairment. One is the semantic form, when we are looking for words to try to express ourselves, and the other one is the amnestic form. I mean, we are misplacing things, the car keys. We are forgetting the name of somebody that we know, but it's not really dementia if we can find the keys. It's not really dementia if we can later on remember the name of the person that we forgot. When we do not find the keys and we are not remembering the name of people that we know, then we are talking that the patient has dementia. Remember, if we have mild cognitive impairment, we have an average of 14% a year, up to 90%, that in the next 10 years, we are going to have dementia. And I tell my patients, easier number to remember is not 14, but 10% a year, up to 90%, that in the next 10 years, we are going to have dementia. Therefore, do we want, just to see the doctor as soon as possible and just be given whatever medication we have out there available to treat the cognitive deficit? The answer is yes. Remember, just only 50% of people who have dementia is being diagnosed with dementia. Why? Because the other 50%, or they were not referred to the specialist, or the primary care physician didn't have time to actually focus into the possibility that his or her patient, may have dementia because he's not following, not taking medications, and the diabetes is out of control, is over-medicating himself. I mean, we need, just to try to think of dementia and start treating as soon as possible. Now, the medication that we have available, the 3 cholinesterase inhibitors and the NMDA receptor blocker, memantine, which what it does, it just blocks the receptor for glutamate. Glutamate is an excitatory amino acid that is extremely important. But at the same time, when there is overstimulation by glutamate, the neurons begin to die because they are working. They leave me, let me rest, And we are not allowing the brain cells to rest, and then they begin to die because of glutamate overstimulation. This medication, memantine, okay, it works in cases with moderate to severe Alzheimer's disease. It does not work in patients with early cognitive deficit or mild cases of Alzheimer's disease. The 3 cholinesterase inhibitors in the market, donepezil, galantamine, and razadine, okay, these medications, they, believe me, they do work. They improve cognition. And I want you also to be aware that really the improving cognition, you see it, for 6 to 12 months after you begin the treatment. And then you say, hey, does it work beyond 12 months? The answer is, you know what? Cognition is not really going to be improved that by much anymore beyond a year. And then why do you keep those patients on this medication if cognition does not really continue to do better? And the reason is because patients can, as I said, slow down the progression of the symptoms, and also those patients, are being helped with behavior, and they are being helped with maintaining their independence with activities of daily living. And to me, that is very important. Remember there are I see a lot of patients who have no health insurance. And I tell my patients, just get this application, GoodRx, and guess what? With this application, you can get donepezil for less than $7 a month. $7 a month, which is affordable for anyone. The minimum effective dose is 5 milligrams a day. And then, you increase it to 10 milligrams a day after a month. I use this medication in the morning. That is my preference. But if you were to read the PDR, it tells you to use it at night. And the reason I use it in the morning is because patients who are on this medication, the cholinesterase inhibitors, they have tendency to dream. And when they do dream, they dream what they have lived during the day. And if they had a beautiful day, what a wonderful thing to do, just to dream all about it. It was a beautiful day if it wasn't a good day. We don't want the patient to be extremely restless at night. We want the patient to at least, try to get some rest. That is the reason, I use it in the morning. Another reason I use it in the morning because this medication have tendency to cause leg cramps, and I mean, many of us, I'm sure that we get nocturnal leg cramps if we are not taking the medication. And when we have leg cramps, what do? We get out of bed, we become restless, we begin to pace around, because we want to get rid of the cramps. That is another reason why I use it in the morning. But as I said, if you just only write once a day, the pharmacy is going to write one at night, which is, that is my personal preference. Now, if you ask me, among the three cholinesterase inhibitors, which one of the three is the one that I write more prescriptions for? And I like donepezil. And you say, why donepezil, Dr. Salazar? Because 84 to 86% of patients can tolerate donepezil with no problem whatsoever. If you were to use rivastigmine, just only 47% of patients can get, to the maximum dose, which is 6 milligrams twice a day. And guess what? Rivastigmine, you begin with 1.5 twice a day for a month, and then you increase it to 3 twice a day for a month. Then you go to 4.5 twice a day for a month. Then you get to the 6 milligrams twice a day if you are lucky enough to tolerate the medication. I mean, twice a day, and I am already forgetful. Do you think that I'm going to be able to remember every single day to take it twice a day? Probably no. Therefore, I like to take my donepezil because the donepezil has a half-life of 72 hours. Therefore, if I forgot tomorrow, I still have my donepezil from yesterday, or I forgot the following day, I still have my donepezil. And guess what? The other medication, another reason why I like donepezil is because when you have to add memantine to these patients, half-life of memantine is 68 hours. Therefore, and then we have Namsari that comes in combination with donepezil. That is the brand name for the combination of donepezil and memantine. It's 1 capsule a day, which is, again, 2 medications with 1 capsule a day. You can simplify treatment, and then you have better compliance, better results probably. When I make the diagnosis of Alzheimer's in my patient, I try to educate the family. I don't know if what I'm going to say is something that you're going to agree with me or not. But guess what? If any of you come to see me complaining of memory loss, probably you don't have dementia because you came by yourself. Usually the patient that I see in my practice, that come to see me for memory loss, they are brought by the significant one. Can be the spouse, can be the daughter, can be the neighbor, can be somebody, who is actually who has noticed that the patient is declining, that is asking the same, that they're repeating the same stories. That to me, that is something very important. I pay attention. And then I have a discussion, not only with the patient, but with the relative that brought me the patient. I said, we need to work as a team here because, my patients are going to do better if you know more about the medical condition that we are treating your loved one for. And I need you to be in good health, to remain in good health, because if you remain in good health, my patient is going to do well. If something happened to you, who is going to be taking care of you? Think about it, just because, there is always that daughter-in-law, it's usually the woman in the family who is the one who is going to be bringing the patient, taking care of the patient. And that patient, that caregiver, has a huge burden to carry. She loves the mother, of course, but she's all of the time becoming very much depressed. And even though she is not my patient, I am always asking, how are you doing? Because I want her to be doing well. That way, my patient can be doing well too. And we go over the what are the symptoms, how the disease begins with, as I said, you forget, the name of people, you are asking the same question, but eventually, you begin to forget not only the name of people, but you are forgetting recent conversation. You don't remember if you had your breakfast and what you had for breakfast or what you had for dinner the night before. If you are watching a series or a TV series, you don't remember, what happened last time that you saw the show. Patients begin to forget important days that you are very familiar with. You not only forgetting appointments, but they forget their anniversary, birthdays. They forget to pick up medication, to take medications as prescribed. They begin to get lost. They begin to just leave the door open, the windows unlocked. They go grocery shopping and they don't find the car in the parking lot. They are cooking rice and chicken, and they go to the store to buy the chicken, because that is what they needed for the dish, and they forgot. They bought everything but the chicken, and they are late paying bills. Sometimes they pay twice. I have patients that they have lost their house, because they didn't pay property taxes. And remember, the city, the city doesn't, they don't have a heart, the city doesn't have a heart saying, you know what, hey, yes, family need to be involved, family need to be conscious that, there is something wrong with mom, there is something wrong with dad, we need to take the patient to my father, my mother to the doctor. I always tell my patients, listen, if my father had, just Alzheimer's disease, my risk later on in life for developing the disease is 2 times higher than somebody who didn't have a father with Alzheimer's disease. If my mother had Alzheimer's disease, my risk later on in life would be 3 times over somebody who doesn't have a mother with Alzheimer's disease. Therefore, hey, risk factor for Alzheimer's, as you all know, is just getting old. Family history, of course, I already mentioned. Having diabetes, diabetes type 1, diabetes type 2, they both, have higher risk of developing Alzheimer's. There is some people coining the diabetes type 3, when they have, a diabetic patient with dementia. Another, just a low level of education is another risk factor, for having dementia. Remember, they have done a study where, amazingly, people who were diagnosed with dementia, and then when they do die and they check, the brain of these people who got dementia, they had not only Alzheimer's disease, but they had vascular dementia, and they had, for example, Creutzfeldt-Jakob dementia, which are only 300 patients in the planet, on yearly basis with Creutzfeldt-Jakob with dementia. Patients, because they are not Creutzfeldt-Jakob is a disease that you get infected with. Remember the mad cow disease, in England. But in Chile, in South America, I come from South America. In South America, in Chile, when they eat the brain of lambs, is when they get the disease, Creutzfeldt-Jakob's, because it's a delicatessen there, just to eat the brain of lambs. I don't like it, but they do, and I don't like it anyway. But anyway, they found that, in post-mortem studies, the patient, they didn't only have one kind of dementia. They had Alzheimer's, they had vascular dementia, they had Lewy body dementia, or, associated with Parkinson-like symptoms. The patient with Lewy body. I know that I'm talking about many things at once, but patients with Lewy body dementia, those patients who are demented. But you know what? They also have visual hallucinations. They see people that they are not there. They see images of something, all the time. They see, and they are staring, at whatever they are seeing. And and all of the time, they are just back to normal. In other words, they have, just moments of clarity where they appear to be normal, and then boom, all of a sudden they begin to see having the hallucinations. It is important, to notice or to distinguish one kind of dementia from the other one. The answer is yes, because remember, when you have those patients who are having the hallucinations, or any demented patient who is becoming very much aggressive, even though we know that any of the atypical antipsychotic medication that we have in the market, and you know them very well, any of the atypicals that we use in anybody who is demented of the age of 65, we are doubling the risk of cardiovascular disease from 1% to 2%. Therefore, think about it. This is your father, this is your mother, and I have to have this conversation, with my patient. Of course, I'm always looking at my patient, not because my patient has dementia and may not be understanding what I say. I'm going to ignore my patient, not at all. I have to look at my patient, at my patient's eyes, at the same time that I'm talking, to the relative that is sitting next to the patient. Anyway, and I explained that we need to use the medication to try to calm them down. Don't use Thorazine, don't use haloperidol, because this is the worst thing that you can do for anybody who has Lewy body dementia. You will make, the Parkinson symptoms associated with the dementia much worse. All right, don't do that. But you can use the atypical quetiapine that actually It's a medication that, even though it's an atypical antipsychotic medication, also has some serotoninergic effect. Therefore, it's a good medication to use. Now, if you have any questions about dementia, you can ask me later. Let me talk to you now about seizures. When we talk about seizures, the patients I get in my practice with seizures are the patients, who are referred to by the primary care physician. And remember, the commonest type of seizures is the partial seizure, not the primary generalized epilepsy. But we all, any of us, can have, just partial seizures, and we have not been diagnosed. And why not? Because nobody pays attention to the partial, simple partial or complex partial seizure. The only reason, any of us is diagnosed with epilepsy when we have a convulsion. We fall down to the ground and we are having a tonic-clonic seizure, that we have their eyes rolled back, and we are biting the tongue, and we are biting the cheek, and we are foaming, we are turning blue, we become very rigid, and then we call 911, they take us to the emergency room, and yes, they diagnose us as having, a seizure and epilepsy. But remember, primary generalized epilepsy, they are not the commonest type of seizures. The primary generalized epilepsy can also come in combination, like juvenile myoclonic epilepsy. They have, absence seizures. They have, just myoclonic seizures, and they have the tonic-clonic seizure. Therefore, this patient who was in the emergency room after a tonic-clonic seizure probably has been an epileptic for the last, 10 years, since he was 15, 16, but was having the absence seizures, the staring spells, the rolling of the eyes, the pausing when talking in a conversation, and nobody pay attention. Or the patient was having, just one myoclonic jerk, a month or once every 3 months, and nobody pay attention, neither the patient, until the patient had, just the tonic-clonic seizure. Is this important? Of course it is important. Why? Because if we use the wrong medications, we are not going to be able to control absence seizures and myoclonic seizure in that patient. We may be able to control the tonic-clonic seizure. Listen, please, when you have anybody you're suspecting seizures, you want to treat them, make the diagnosis soon, and begin the treatment as soon as possible. Why? First of all, I want you to know that only 64% of patients with epilepsy can be controlled with medication. That is the Kwang and Brody study published in New England Journal of Medicine in the year 2000, 64%. And that is, using polytherapy, because when you see a patient with epilepsy, you do your clinical history, you see that this is the best medication for the seizure type that the patient has. And you put the patient on that medication, and the patient comes back with the seizure diary a couple of months later after you have titrated up to effect, and the patient is coming back having seizures. Oh my gosh, you know that you are encountering a problem, because with the first medication that you normally choose to treat epilepsy with, you have 47% chance of controlling the seizures. If the patient came back after a couple of months having seizures, oh my gosh, you are going to go with the second one, you titrate the second one to effect, and then you win the first one, and you see, okay, keep your seizure diary, and let's see how well you do. By doing that, you're increasing from 47, you're increasing it by 13% the chance of controlling seizures up to 60. And then the patient comes back and the patient is still having seizures. In the back of your mind that you have somebody who has refractory epilepsy. And then you're going to use the third medication, and by doing that, titrating up and withdrawing the second one, the second drug that you use, you have only 1% chance, a 3% chance of controlling seizures. The patient comes back to you still having seizures. Now you're going to use combination therapy, based on many things. Efficacy, safety, and tolerability. You see you ask the patient which of the medication that you have tried, you like better, which one has the least side effect for you. You see the seizure diary to see, which one of the 3 medications, was more effective. You use combination therapy, and then by using the combination therapy, you improve it by 1%. That is the 64%, and then you have 36% of patients who are not, okay? Why is it important to make diagnosis of epilepsy early, as soon as possible? Because of sudden death, sudden unexpected death in epilepsy. And you need to educate your patients about that, because that also allows you to have better compliance with medication. many people, because they have one seizure here and there, they think that, well, I missed my medication today. It doesn't really matter because it has happened 3 other times and I never had a seizure. Sudden death, I always tell my patients, if you have 100 people with epilepsy and only one is non-compliant, who has the higher risk of having sudden death? The guy who is not taking the medication. The other ones, they still have sudden risk or sudden death risk, but their risk is going to be lower because they are taking medication. The ones that are controlled, they have lower risk of experiencing sudden death. Therefore, it's absolutely important. Remember, also another piece of advice. Many times, patients say, hey, doc, for how long do I need to take medication? And I said, just that answer, is no, don't do it for any less than 5 years. Barrow Neurological Institute, they tell you 2 years without seizure-free, you can wean yourself off the medication, we can wean you off. I do it, just 5 years, the longer the better in my case, and I make it very difficult to my patients, and I tell my patients, you know what, if you are 5 years without having a seizure and you have not missed one dose, then I will consider, weaning you off. Only if the patient has normal neurological exam, normal MRI, normal EEG. If the patient has anything that is abnormal, any of the three, I would not. Okay. Another thing that you may have, another question that you may have for me is, Dr. Salazar, after I had my first seizure, do I need to be treated? And the answer is no, it depends. If you have 2 or more unprovoked seizures, then you have the diagnosis of epilepsy. Because you can have a seizure because you didn't sleep for 3 days. You can have a seizure because you had too much to drink. You had alcohol withdrawal seizures. Or you can have a seizure because you have high blood sugar or low blood sugar. If you have 2 or more seizures, 2 or more unprovoked seizures, you are an epileptic. Okay, period. Now, if you had only 1 seizure, I ask the following question: Were you a full-term baby? Yes, I am. Good, I was. All right, great, fantastic. Were you born in the hospital? Yes, I was. Normal vaginal delivery? Yes, I was. Did you stay in the incubator? No, I wasn't. Did you go home together with your mom, 2, 3 days after birth? Yes. Did you have meningoencephalitis as a child? No, I did not. Did you have febrile seizures as a child? No, I did not. Do you have any history of significant closed head injury associated with loss of consciousness? No, I did not. Okay, if your neurological exam is normal, your MRI is normal, your EEG is normal, I'm going to give you the benefit of the doubt. You see what I mean? After you had the first seizure, what are the chances of having a second seizure? It's around 30%. After the third seizure, you have 50%, and after the third seizure, you have 100% chance that you're going to continue to have seizures. And remember something else. If you are very well controlled on medications, if for whatever reason we decide to wean you off, because you were asking me, hey, doctor, so many years without having seizures, wean me off. Okay, we go through the process of studying you again, just to make sure that we are not missing anything. We wean you off, and guess what? A month or 2 or 6 months later, you have another recurrent seizure, and we put you back on. You put yourself back on the same medication that control your seizure for 5 years, for 6 years. The same medication at the same dose doesn't work anymore. But how can that be possible? The medication hasn't expired, doctor. Why I'm having seizure? Tachyphylaxis. You see what I mean? In other words, unfortunately, we lost a medication that controlled your seizures greatly, 100%, for so many years, and now reusing it, it doesn't work anymore. We need to begin from zero. The other thing, changing the topic of conversation, we talk a little bit about dementia, we talk a little bit about seizures, now about stroke. There are 2 different, when we talk about the stroke or cerebrovascular accident, there are 2 different types of cerebrovascular accidents, if you wish. One is the ischemic type, and the other one is the hemorrhagic type. The ischemic type could be for many reasons. It can be for a thrombus, can be, the carotid artery stenosis, a piece of a carotid plaque, can be breaking off and travels up to the brain, it causes an embolic stroke, thrombotic stroke, ischemic stroke when there is intracranial atherosclerosis. What are the risk factors for a stroke? You all know: hypertension, diabetes, hyperlipidemia, family history of a stroke, heart disease, cardiac arrhythmias, atrial fibrillation. Remember that 30% of embolic strokes due to atrial fibrillation are going to become hemorrhagic strokes. Therefore, when those patients get into the hospital and you know that the patient had an embolic stroke because of a new onset atrial fibrillation, yeah, you can put those patients in anticoagulation, but don't be overly aggressive. Just begin, just to anticoagulate the patient, and don't be aggressive for the first 72 hours. Because if you are very aggressive with anticoagulation within the first 72 hours, you can make the non-hemorrhagic stroke into hemorrhagic stroke, and the prognosis is not going to be good. I always tell my patients, we all probably have walking in the middle of the night, with upper extremity, like, I sleep wrong, doctor, because I cannot move my arm or my hand is numb. And I said, okay, yeah, it could be that. But if you are already awake when you are saying that, you're noticing that, I want you to do this for me. Just hold, your arms like this and put them at the same height. You are laying in bed, looking at the ceiling. Just do this and then close your eyes and see, count to 10 and see if you have any drift, that the arm is falling down, or that the arm is doing this, or that the arm is going up. If you find, after, this time that any of this is happening, you're having a stroke. You see? Also, what you may want to do is just think of something that you want to say loud, like, Mom, I love you. And then you listen to yourself. Mom, I love you. Then you know that you're having a stroke. Wake up your spouse, and call 911. Call 911 or go to the emergency room. I would recommend for you to call 911. I don't care if you live 1 block away from the emergency room. Call 911. Because, but doctor, I'm going to make it faster if I drive to the emergency room. No, you may get there faster, but your treatment is going to take longer. You get 911. If the ambulance, the EMT is going to find out that you are having a stroke, they're going to be in communication with the hospital emergency room. And then, they are going to be preparing the TPA because they have to mix it up. And then, by the time the stroke team is going to be waiting for you, by the time that the ambulance gets to the emergency room, from one stretcher, you go to the other one, and then you go directly into the MRI suite. You do, the diffusion MRI scan, you see that there is no contraindication for the use of TPA, and you get the TPA right there in the MRI suite. You didn't have to sit down and check in the emergency room and do anything like that, okay? Remember, we had the window of opportunity, 4.5 hours, sometimes can be stretched up to 6 hours. The risk of intracranial bleed, it is higher as the longer we deliver TPA. Our goal would be to be getting TPA, within the first 60 minutes. Remember, when we have a stroke, we are killing, 2 million of neurons a minute. And then after a stroke, our brain is aging 3.5 weeks. Just like that, 3.5 weeks. Therefore, just go to the emergency room. If we get TPA within the first hour, the sooner the better, says 30 minutes or 45 minutes, 60 minutes, we have better chance of walking out of the hospital into our house instead of being discharged to inpatient rehabilitation for 3 weeks or longer. I wanted just only one more thing, and I promise that I stop talking. I want to talk about POTS. POTS is something, Paul, that you see those patients, in your office, and I see them, and sometimes I miss those diagnoses, I am assuming. But you know what? I want you to remember that there is a medical condition called POTS, which is, just postural orthostatic tachycardia syndrome. Okay, that's what POTS mean. I'm not talking about POTS disease, remember tuberculosis, I'm talking about postural orthostatic tachycardia syndrome. Those are the young people, 24, 25-year-old, who have 5 fainting spells a day many times. And the only way, cardiology can make the diagnosis, you put a link, and then you find that the heart rate went up, for 30 beats, per minute. And in children, it has to be 40 beats per minute. But if we don't do that, Paul, we will miss those diagnoses, because when I see a lot of patients with the syncope workup, yes, you do the EEG, because of it could be the patient had a seizure, an atonic seizure, drop seizure, or the patient had vertebral basic insufficiency. But no, because vertebral basic insufficiency is just clinical history, please. The clinical history is the most important thing. You have to get out that information from the patient. You have to ask the question over and over until finally you get the answer. Vertebral basic insufficiency. How many patients do I see? Please, I ask you, please, you people listening to me, when you go to see your doctor, just make sure that your doctor is checking your blood pressure at least once a month or once every 6 months. Nowadays, it's not the doctor checking your blood pressure. Think about it. When was the last time that you went to see your family doctor and your family doctor checked your blood pressure? You answer that question to yourself. Just make sure that you have the blood pressure checked by your doctor once in a while at least. And if I go to see my family doctor for dizziness or vertigo, I want to have my blood pressure checked in both upper extremities. Why? Because if I have 120 over 80 here and I have 80 over 60 here, I have subclavian artery stenosis as being responsible for my syncope, for my fainting. Just right there without doing anything else. And when you are doing carotid and vertebral ultrasound, yes, that's good to know. Do it. But sometimes it's a good idea. And I educate my patients, after you finish with the carotid and vertebral ultrasound, tell the technician to repeat the testing in the vertebral artery doing isometric contractions. Just contract the hand to see if there is retrograde flow. Because that is when you see the retrograde flow and then you confirm the diagnosis. Doctor, I'm doing an MRA, I'm doing a CTA, and that is good enough. There is beautiful flow. There is beautiful flow, but you don't, the MRA or the CTA, if you are reading it 2 days or 3 days after the test as a outpatient procedure, how do you know if the flow that you see in the artery is retrograde or antegrade? You are seeing a static picture. Yes, there is flow there. You see what I mean? There is a big difference. Okay, it is of course different when you have the radiologist right there is looking at the pictures, at the moment that the patient is getting the CTA, they get the MRA, then you know. If not, that is what I had to say. I'm getting signals that I am over my time. All right, thank you very much. Thank you. Yes. They have what? Yes, they have visual hallucination with Lewy body. Yes, with Lewy body dementia. Yes, they do have. They look like Parkinson's patients. They look exactly like Parkinson's patients, and they have the visual hallucinations. Okay, and you have to use the atypical antipsychotics on these patients. Eventually, you will have to use it. When you have the pure Parkinson's patient, remember, in Parkinson's disease, there is Lewy body too. You see what I mean? But the dementia associated with Parkinson's disease, yes, they do have Lewy body, but it's a subcortical dementia. It's not a dementia. It's not a cortical dementia like any of the other type of dementia that we were mentioning. And there is a condition that's called just Lewy body dementia, and at the Lewy body dementia, they don't even have at the beginning Parkinson's symptoms, but as the disease continues to progress, they begin to behave and to have, the Parkinsonian syndrome, the rigidity, the resting tremor. It's like a Parkinson's disease. But in Parkinson's disease, primarily, they don't have dementia. But everybody with Parkinson's disease is going to develop dementia, usually 2 years after the diagnosis, so within the disease. They develop the dementia. The dementia is not as profound as you would expect to see, in Alzheimer's disease, but they develop dementia. Yeah. And you know what? It's very contagious. I published a paper, about Creutzfeldt-Jacobs, and it's very contagious. You know why? People who have gotten corneal transplant from patients who have Creutzfeldt-Jacobs, they got the disease. Yeah, and something that is interesting, when they have collected the fluid of these people and they put it in paraffin, because they want to do research later on, and then when they had it the storage there for years and years, and they bring it out, they can transfer the disease. Yeah. Did you do a paper on it? No, it was I published it when I was at the University of Arizona. Yeah, I published it. Yeah.
Quick question, why do providers not prescribe Xeric as often as they should, considering that there were two pills that can be taken?
I don't know. I try, remember Namsaric, Memantine does not work, in early onset Alzheimer's. We know that they have done plenty of studies, it doesn't work. But then, when you add memantine, after, as I told you, the effect of the cholinesterase inhibitors wanes, within the 12 months or so, then yes. Actually, it wasn't a paper that I wrote, but it was a case presentation at Grand Rounds. I remember that I had to read, and review the literature in order to present that case. We had a patient, in Tucson, and the reason we had the presentation was because there were 3 cases of Creutzfeldt-Jacobs at the same time in Tucson, Arizona. 3 cases at once, and they were not related one to each other. You know what I mean? They were not related. And as I told you, normally you have 300 cases in the world, and you here in Tucson in the 1980s, you had 3 at once. I remember that NIH, was involved trying to find, the cause of that. Yeah. Yeah. Talking about multiple sclerosis, and when I have a patient with Black patients, with MS, I recommend being aggressive, treat, MS in Black people, because the disease is really nasty in Black people. You have to be aggressive. Don't waste your time. I would say so. Using Copaxone or using Copaxone or using beta interferon. I think that we should nowadays, with the newer medication that we have, we should start with a stronger medication, because they have tendency to have MS plaques in the spinal cord, and they progress more rapidly, in their disability. They have lesions in the posterior fossa, and it's better to be aggressive. Yeah.
Well, Dr. Salazar,
Yes.
I love your passion.
Oh, thank you.
See the way you present.
Thank you.
I thought I was the only one.
Thank you. Thank you.
Dr. Salazar is very passionate. We met in like 94 at Eagles Memorial Hospital.
Yeah.
Wow.
His energy is still there.
Yeah.
I thought I actually got hyped.
Yeah, I was telling Paul that I was not going to be presenting a slides, to be honest, because I saw that I could, I like, just like you did in your presentation, to talk, and I just like to relate to my patients, to people. And if we present the slides, I was thinking that I would want to have a lot of people. You see what I mean? And I said it was going to be easier for me to relate that way. But I did what I could.
No, you did.
Thank you very much.